So as you see, today's topic is a question and answer session on coronary artery disease. That's exactly means by left-sided function. Then cardiomyopathy and right heart diseases. I'm sorry for the last week. Somehow we could not hook up despite our best efforts. And today we have everything in reserve, whether it's a laptop or internet connection, to take care of these issues. So moving forward, the first question is, I'm going to pause or present to Dr. Balram. Dr. Balram and
Yes, sir.
Vasudev Utpal. If Dr. Balram is not able to answer, Dr. Vasudev Utpal will take over. What is the wall thickening abnormalities in this patient? Dr. Balram.
So first looking at the 4-chamber, I would say thickness abnormality. I can see it seems like the septal area is not thickening.
Very, very precise. What septal area?
It seems like the basal septal area and the medial
Septal area.
mid-septal area.
Okay.
And the mid-septal area are not thickening.
Okay. Then we move on to 2-chamber view.
Yes, sir. So 2-chamber, we're looking at the anterior and the inferior part of the left ventricle. It seems normal, a normal wall motion to me.
Okay. 3-chamber view.
Looking at the 3-chamber view, I would say the anterior septal area seems maybe a little less thickening, maybe hypokinetic, I'm not sure.
Dr. Balram, you have to be either hypokinetic, akinetic, normokinetic, or dyskinetic. Yes or no? There cannot be like maybe or may not be.
Yes, sir.
You should be very specific.
I would say possible hypokinetic. I would say hypokinetic.
Hypokinetic, which segment?
The basal septal area.
Basal septal area, I agree. Basal septal area is hypokinetic.
Yes, sir.
Here, I'm talking, you said basal anterior septum.
Right.
Is it normal, abnormal?
I would say hypokinetic.
Hypokinetic, okay. So if your basal anterior septum is hypokinetic and basal septum is hypokinetic, which territory of a coronary disease is involved?
RCA.
RCA supplies to what?
So the RCA would apply to the medial septal area and the basal septal. And the if we're speaking of the anterior septum, that would be more the LAD.
Correct. So you're talking of 2 different segments at the same time.
Right.
You are saying that RCA and LAD, there are 2 segments which are involved. If suppose LAD is involved, will you find only basal anterior septum which is hypokinetic?
No.
Which particular artery of a basal anterior septum, which particular coronary artery branch supplies to basal anterior septum?
Basal anterior septum, the second OM. I'm not sure.
Okay. Dr. Utpat?
Yes, sir.
Explain me which particular artery supplies to basal anterior septum first, basal anterior septum. Which particular artery branch?
First septal, sir. First septal of diagonal, LAD.
septal first perforator of LED supplies it. If the first perforator is involved, do you think that we can have an RCA which is involved at the same time?
Sir, if RCA is involved, the inferior wall should have some changes. Like in two chamber view, uh, apart from the anterior septum, some changes should be seen in the inferior wall also.
Yeah. It should be basal septum, mid septum, basal and mid inferior wall if you are talking
Yes.
of RCA.
Yes, sir.
And it's very unlikely that only the first perforator gets involved, except for the fact which happens when we find only first perforator is involved, is the iatrogenic process.
Okay, sir.
In cases where we have done hypertrophic cardiomyopathy, first perforator septal ablation,
Ablations. Right, sir.
we have injected alcohol to it. Now look, go back and look carefully. Is it first basal anterior septum is involved or not?
Yes, sir. Basal septum is involved.
Basal septum is involved, but basal anterior septum
Anterior, no,
does not look.
no, sir. It doesn't sit so, sir.
If you look carefully, both you and Dr. Balram, this part is not thickening at all. Even this part is little hypokinetic as compared to this part,
Okay.
Inferior,
basal inferior wall.
basal.
And mid anterior basal anterior septum, basal and mid, they are reasonably thickening. Compare with the opposite segments. And majority of time when we are talking of a wall thickening abnormalities, we have to go along with the territory supply. Is it very unlikely? You find one subperforator is involved, other is basal RCA is involved, is quite unlikely, except in one condition. What is that condition is? When you have Takotsubo cardiomyopathy. The Takotsubo cardiomyopathy will involve either the apex or the base. Apical ballooning or basal ballooning. Apical ballooning is known as true Takotsubo and the basal ballooning is known as reverse Takotsubo. Okay?
Yes, sir.
Good. Don't go away, we will be coming back to you again and again.
Yes, sir.
Okay. Anything else, Dr. Tushar, in this patient? Apart from the wall thickening abnormality, anything else do you find, Dr. Tushar, in this patient? Dr. Tushar, are you there? No. Dr. Tiam Banikyu? Time? Dr. Ghanshyam Motisaria? Are you there, Dr. Ghanshyam?
Yes, sir.
Anything else you find in this particular?
Sir, sir, I have confusion. There is something like non-compaction cardiomyopathy.
Yes. Why did you see that?
There is a seal-like structure in apical thickening.
All apical segments show sieve-like structures.
Yes.
Here, here, here. Good answer. Are we dealing with possibly non-compaction cardiomyopathy? That could be a possible answer. Suppose it's non-compaction cardiomyopathy in Dr. Ghanshyam,
Yes.
how do you prove that this patient has got a coronary disease?
How do I prove?
How do you analyze that this patient could have a coronary disease? As your colleague said, basal septum appears to be hypokinetic. Basal inferior wall, I said, is hypokinetic.
There
Then
is
how-
a kinetic movement of apex. It's going away from when systole.
I'm sorry, say it again.
This kinetic movement of apex.
Where?
Apex.
Which view?
Apical.
Which view?
Four chamber view.
No. No way. Normally contract. You give a good answer and now you have done a blunder. What do you mean by dyskinetic, Ghanshyam?
Dyskinetic means thinning.
Dyskinetic means bulging out with systole.
Yes.
So now concentrate on this segment. Is this bulging out? I'll just play it again for you. Look, it's not bulging out. It's coming inside.
Yes, sir.
Thinning is a different phenomena, but this is not bulging out. Dyskinetic means which bulges out. So your pickup of non-compaction possibly may be right. I'm not saying no. And if you have to assess a coronary artery disease subset of patient, put them on a stress, put them on a dopamine echo, or get a CTA coronary angiogram done, or coronary angio.
Oh, yes, sir. I got it.
If I would be the treating physician, I'll put these people on stress echocardiography to assess in significance of these valvular abnormalities. Right. That's what you said. Okay. After this, Dr. Rahul Kenkan. Rahul, are you there?
Yes, sir.
Rahul, what exactly, like what injection fraction you will expect in this patient?
Sir, around 30 to 40, sir.
No. Eyeballing 32? Oh, no. Dr. Krishna Ansiram Yadav. Dr. Ishwar Agarwal, you can take this question. Injection fraction.
20 to 25%.
Pardon?
So 25 to 30%. Most
Injection fraction would be low. I don't say 25 to 30%. Would be about 40% of ejection fractions.
Sir,
But anyway, you have to trace, like if I would be the treating physician again, I always trace ejection fraction where I see some amount of wall thickening abnormalities. I spend time in calculating ejection fraction by modified equation. Okay. All right.
sir, one more thing.
Go ahead.
Sir, instead of going for CT angiography, can we just do tissue Doppler imaging to define if it has CAD or not? Like
Well,
ischemic cardiomyopathy.
conclusively, you cannot say that.
Okay.
It can suggest you, but it will not tell you conclusively. Please silent mic. Everybody, please silent mic. Dr. Pawar. If I would be treating physician, I'll always go for a stress echocardiography in this patient. Okay. Next question. Suppose this ejection fraction is normal. My question is very specific. Suppose this ejection fraction is normal. What is the diastolic dysfunction in this patient? Dr. Rahul Kenkan and Dr. Krishna Ansiram Yadav. You have a value in front of you. You have a EA ratio 0.53, E
Yes.
prime septal 5, E prime lateral 7, average 7'40", and LA volume 44.6 ml. And then you have a gradient of TR, which is almost 3 meters per second.
Yes, sir. Sir, Dr. Rahul here. Sir, this looks to be grade 1 DD.
Why did you say grade 1, Rahul?
So E by A ratio is less than 0.8, and even LA seems to be enlarged. The tissue Doppler E prime also is less than 7, and we are also getting a TR jet more than 2.8.
Then how to calculate LV dysfunction in normal diastolic function in normal subjects?
Sir, we see 4 criteria. The E by A ratio, if it is less than 0.8 or more than 2, the E prime septum less than 7, the E lateral less than 10, or TR jet more than 2.8, or LA, the LA volume index more than 35, more than 34.
34.
If more than 3 criteria are fulfilled, then we can label it to be as diastolic dysfunction.
Grade 1. So if you
Yes.
said grade 1, let's see what is grade 1 is. So this is 0.44, 0.83, 53, 5, 7, 725, 46.16. Then TR gradient of almost 3 meters per second. And if you put these factors together, Dr. Krishna iPhone, Dr. Krishna. You put these factors together like 0.53. So it comes over here 0.53, grade 1. Correct? Then E and E average 7.25. It comes over here. TR jet velocity less than 2.8. This is higher on this side. Then LA volume is 46.6 ml. This is increased. So possibly this patient belongs to grade 1 diastolic dysfunction with raised
Yes.
LA volumes.
Yes, sir.
It's not grade 1 alone. It's a grade 1 with raised LA volumes.
Yes, sir.
Okay. Great. Good.
Thank you, sir.
Let's move to Dr. Krishna Ansiram Yadav. Dr. Yadav? Are you there, Dr. Yadav? Okay. Mrs. Jigna Varesh and Jayanti together. Jigna, tell me the wall motion abnormalities in this patient.
Yes, sir. Good evening, sir.
Good evening, Jigna.
So in fourth chamber, we can see the thinning out and akinesia of apical septum, and rest of LV is hypokinetic, sir. And
We
in
don't have rest of the LV. We have a LV which has got another 5 segments in a patient.
yes, sir. Sorry, sir. Sir, the apical septum is thinning out and akinetic, and the basal and mid infroseptum, basal, mid, and bicolateral is hypokinetic. Sir, view is little bit suboptimal, sir, but in the 3 chamber, we can see
Images are not great. I do
Yes,
agree.
sir.
I'm not saying that. But this is what we get every day in our practice, you know.
yes, sir. So in 3 chamber, we can see hypokinesia of mid infralateral and apico-infralateral, sir. Apico-infralateral and
Look, Jigna, it's very clear like this segment is akinetic.
yes, sir.
This to be hypokinetic.
Hypokinetic, yes,
These
sir.
are normokinetic. This is normokinetic.
Okay, sir.
Then when you have this kind of abnormalities of which correspond to
LED
which one?
territory.
LED territory.
LED
Then
territory,
what
yes,
other
sir.
territories are there in this 2 chamber view?
Sir, anterior and inferior.
Which anterior and inferior?
Mid basal and apico anterior, and here we can see
We should see whole of the anterior wall.
yes, sir,
and we
whole
should
of the
see
anterior
apical
and wall.
inferior wall.
Yes, sir.
So concentrate on apical inferior wall over here. Is it contracting? Is less contracting? Look, this is less contracting.
Less contracting, yes, sir.
Then concentrate on apical mid anterior septum and basal anterior septum. They are also hypokinetic.
Less
Or in fact,
contracting,
they're not playing. And this corresponds to LED territory. So once you get a clue, then you should start looking for corresponding segments in other views also.
Yes, sir.
And this patient has got an apical septum, which is almost akinetic.
Yes,
And LV, if look at the size of LV, what's the size of
dilated.
LV? Dilated.
Dilated, yes, sir.
Yes. LV is dilated, segment is akinetic. This patient comes with a chest pain. Would you classify them in acute or chronic?
Thinning out is sir, because that segment is thinned out, so we can tell this as a chronic.
Correct. Once
Yes.
the LV starts dilating and the segments appears to be thinned
Thinning.
out,
Yes.
and whether the patient comes with the chest pain then or before, but we suspect these patients have an old insult,
Old MI, yes, sir.
not an acute MIs,
Yes, sir.
right?
Yes, sir.
Okay, good, Jigna, great work.
Thank you, sir.
So Jayanti is there?
Yes, sir. Yes, sir.
Oh, Jayanti, you have to tell that that patient was not doing well as far as the LV function was concerned. And these are the parameters for diastolic function for that patient. Looking at these parameters, tell me what is the diastolic function of this patient?
1.4.
Ejection fraction is reduced, 35.
Yes. Yes, sir.
So what is the diastolic function in this patient?
Yes.
Gerda waiting.
Uh, 2.2. So grade 2. Hello.
You have to be very confident.
So grade 2 diastolic dysfunction.
You know, like when we talk something, we should, even if we are saying wrong, we should be as comfortable in talking. Look, so that is the only thing which is possible.
Grade 2, sir.
Why do you say grade 2?
Because sir, EA ratio is 1.47, which is more than 0.8, and E wave
You look at a chart
E wave
of
is
these.
less than 0. E wave is also less than
When I showed you these pictures with TR jet velocity and everything out there, then you did not ask me E prime septal lateral walls at all. So if I put all these factors together, EA ratio 1.47, correct? E prime septal 5, E prime lateral 7, EN average is 21.5, TR jet velocity is 2.29, TR gradient of 21 millimeters of mercury, correct? Now look at this with reduced ejection fractions. So where does we fall in E wave less than 0.8? We do not fall in less than 1.8. E wave is more than
50.
80, more than 50, sorry. So R is more than 50. Here E wave is less than 50. So first of all, we do not belong to grade 1 at all.
Grade 1.
No, we do not belong to grade 1. Then we belong to this category where E wave is more than 50. Then E ratio is between 0.8 to 2. Here my ratio is 1.47.
1.47.
So I have to look at this category of in between. Then once you get into this parametry, 3 criteria are there. One is E to E prime ratio average. What is my ratio? E to E prime average.
21.5.
21.5. So it's positive.
Which is more than.
TR jet velocity is 2.8, which is not there. Then LA volume. Index LA volume more than 34 cc. Let's see what was the volume in this patient, last patient. LA volume in this patient is 46 ml.
Then 2 criteria are positive.
Criteria are positive. If 2 criteria is positive, this patient belongs to grade 2.
Grade 2.
You should have these charts in your lab, Jayanti. Like what we do, we have these charts, like we have laminated them, and their ready readiness in the lab also. Right?
Yes, sir.
So it was not grade 1, it was grade 2.
I said grade 2 only.
Okay, then that's good. Great. All right, Jayanti. God bless you. Let's go to the next person. Next person is Dr. Ranjit Shankar Mohite. Ranjit,
Yes, sir.
your turn. Just a second. It needs little adjustment. So now tell me, Ranjit, abnormality in this patient.
Sir, LV looks dilated and LED territory area, mainly the apical septum and apical lateral looks hypokinetic, and there is MR also.
I'm not satisfied as yet. Let's take segment by segment. In 4-chamber view, basal septum,
Normokinetic,
normokinetic. Mid septum,
hypokinetic,
apical septum, mid septum,
akinetic,
akinetic. Look, this is almost thinned out, man. How can you say it's a normokinetic or hypokinetic? It's almost thinned out segment.
Yes, sir. Akinetic.
Dilated LV thinned out segment. So mid and apical, you say virtually apical half of LV, apical septum, apical half of septum, apical lateral wall, which is hypokinetic. Then in 3-chamber view, look very carefully, look 3-chamber view. Even this segment is mid septum is all thinned out completely.
Yes, sir.
And look at this 2-chamber view. Anterior septum is hypokinetic. Anterior is this. Inferior is hypokinetic. Correct? So when
Yes,
these kind of things, which territory of coronary artery?
LED, sir.
LED. Okay. Good. So what exactly is ejection fraction you will expect in this patient? Ranjit?
30%, sir.
Around 35%. Look,
Yes.
remember, how do we calculate is when we have LED involvement, ejection fraction drops down to almost 30-35%.
Yes,
When
sir.
we have a RC involvement, if RV is involved, that's a different phenomena. But if RV, basal and anterior, basal septum, mid septum, basal and mid inferior wall are involved, the ejection fraction is around 45%. Same is true for lateral circumflex also.
Okay.
Right. So that's how we remember all these segments analysis. But good attempt, Ranjit, but you may have to move a little better than this. Okay. Next person. Dr. Bhatkar Dilip Pandit.
Yes, sir. Good evening, sir.
Good evening. Dilip, wall motion abnormality.
Yes, sir. Sir, in 4-chamber view, basal septum, basal and mid septum is hypokinetic, or basal septum is akinetic. Mid septum is also hypokinetic. Then apical apex is contracting normokinetic. Apical lateral is also kinetic, normokinetic. Sir, only basal septum and mid septum are akinetic, sir, in 4-chamber view.
Okay, good. Only this part appears to be hypokinetic. That's all, nothing more than that. Good attempt, Dilip.
Yes, sir. Yes.
Dr. Dinesh Kumar Tiwari.
Yes, sir.
Your slides are right in front of you. This is a case of postpartum cardiomyopathy. Hint is there. What are the abnormalities we are seeing in this patient?
In first fourth chamber, there is dilated left ventricle, and there is moderate MR, and there is seems to be global hypokinesia.
I told you postpartum, so it's global LV hypokinesia.
Yes.
That's not true, man. It's reasonably a good contracting LV now. Only thing is spongy myocardial dysplasia with moderate mitral regurgitation. This is one of the few patients which improved dramatically with postpartum cardiomyopathies. Okay, Dinesh? And what are these segments are? What is this abnormality seen over here?
This is a CV-like pattern as in
Yes. Suggestive of
non-compaction cardiomyopathy.
non-compaction of heart disease. Right. Let's move on to Dr. Bhimrao Pawar. Dr. Pawar, are you there? Dr. Rakshit Bhardwaj. Dr. Ankan Patel.
Yes, sir. Good evening, sir.
Ankan, tell me the wall motion abnormalities in patient.
Sir, in this view, sir, the apical cap is, sir, hypokinetic, sir.
Okay.
And sir.
All right. Anything else?
And sir, the septum is no, sir. Only the apical cap is hypokinetic, sir. Like that.
Septum is normal, man.
Well, sir.
Yeah. What's wrong with the septum? It's doing reasonably well.
Yes, sir.
Any abnormality?
Sir, only sieve-like structures are there, sir. Non-compaction maybe.
Sieve-like structures are there. LV function?
Sir, it is around, sir, 50 to 58%, sir. Normal.
50 to 55%. All right, Ankan. Let's move on to Nitin Gupta. Nitin, describe this image. Are you there, Nitin? Dr. Muhammad Hiru Al Amin.
Sir, good evening, sir.
Good evening, Hiru. First of all, I must congratulate you or must wish you a very happy Eid. Thou 1 week later.
Thank you, sir.
Thank you, sir. We had this. And I got your message also at the same time. God bless you, dear.
Thank you, sir.
Tell me, Hiru, any abnormality in this view?
Sir, this is apical two-chamber view showing the inferior wall and anterior wall is normokinetic, sir.
Okay. No.
Sir, just a basal part of inferior wall is hypokinetic.
Possibly hypokinetic, right?
Yes, sir.
One more view I'll show you.
Yes.
Look at this view. Any abnormality?
No, sir.
All right. There is no except for the fact apical septum and basal inferior wall. This is the same patient which I showed you 3 slides together. Follow-up case of postpartum cardiomyopathy. Now look at this function over here. This function over here. This function over here. And some amount of mitral regurgitation.
Regurgitation. Yes, sir.
Good answers. So, Hiru, I'll move on next person, Dr. Sirisha. Sirisha, are you there? Dr. Ganesh Tukaram Thomre. Dr. Ganesh. Sayali Nand Kumar Bhangre. Dr. Sumant Kumar. Dr. Anupa George. Dr. Ishwar Agarwal.
Yes, sir.
Ishwar, tell me the wall motion abnormalities in this patient. Very clear wall motions are there.
Apex is contracting normally.
Okay.
The basal and the mid part of mid septal wall, they are hypokinetic. The lateral wall is possibly a bit of hypokinetic.
Okay.
Apex is
Go to 3-chamber view.
so the same. The septal, basal and the mid septal wall, they are hypokinetic in this also. Short axis view.
Very short axis view.
So this the third view.
Third view is this is short axis. No, this is not.
No, sir. Cross sectional view of the left
This is
ventricle.
2-chamber view. What is this abnormality of this patient? Is it normal or abnormal?
Dyskinesis, aneurysm.
Where do you say sinus of aneurysm, man? That you see in parasol short axis view at aorta. Here is not the sinus view. This is apical 2-chamber view, foreshortened 2-chamber view with one very significant finding. Can you see this finding over here?
So this is bulging out of the ventricle wall.
Correct.
This is
What does it mean by?
aneurysm wall or dyskinesis? This is
Bulging out means dyskinesis. Persistent bulge is aneurysm. Is it dyskinetic or aneurysmal?
dyskinesis. Dyskinesis. Sorry.
So this segment is contracting in and this is going out. So somebody who's asking dyskinesis, here is a classical dyskinesis. All right?
Yes, sir.
Suppose this patient has got, as you said, basal lateral is hypokinesis, basal inferior is hypokinetic, basal anterior wall is hypokinetic. So what we will find about mitral regurgitations?
Sorry, then why don't we find MR?
Will you find MR or not? If yes, why? If you not, why?
Sir, basically bulging out, we have got the space, so for the blood to collect.
No.
That's why MR, we don't see MR in this.
It's not right. So whenever you have a papillary muscle which is involved, the papillary muscle is attached to either basal lateral wall or basal inferior wall. So basal lateral wall is hypokinetic also. Here basal lateral wall is hypokinetic, basal inferior wall is hypokinetic. So you expect a significant of mitral regurgitation in these patients. Okay?
Okay, sir.
Then we go to Dr. Amit Potulwar. Amit, are you there? Dr. Umesh Rajur.
Yes, sir.
Umesh, tell me wall motion abnormalities.
Sir, in 4-chamber, apical septum, apical later are akinetic, sir.
Okay. And
in 2-chamber, apical anterior and mid anterior.
Okay.
Even basal anterior is also involved. Looks like
Basal-
LED.
Okay.
Looks like LED involvement, sir.
Okay. Dr. Safila Vishal Sardesai. Safila Vishal Sardesai. Are you there, Dr. Safila? Mitul Jain. Dr. Mitul Jain. Namdev Limbaji Chaure. Dr. Namdev. Dr. Suman Chatterjee. Anchala Singh. Rahul Gore. Rahul, are you there?
Yes, sir.
He said
Yes,
apical
sir.
segments are involved. What's your view about apical segments?
Sir, there is a involvement of yes, sir. There is a apical segment is involved. Also, there is thinning out of apical lateral and apical septal segment involved.
And look at this contraction over here. This is thickening. This is thickening significantly. But don't think if somebody is asking you a question, he'll give you all abnormals. This is fair good example of a normal echo.
Sir, this second image, I am not getting correct.
Pardon?
Sir, this okay, sir. Now getting, sir. This is normal.
All are contracting very well, man. Look, this is endocardium seen over here. Endocardium seen over
Okay.
here. Look at this endocardium.
Okay.
This is endocardium.
Okay, sir.
If you hand over everything to a secretary, she'll not do something which you will do. And if she knows as much as you know, then she'll not be your secretary. You will be her secretary. Okay? So we have to be very, very specific. Rahul.
Okay, sir.
Umesh, I'm sorry to say that there is no wall motion abnormality in this.
Okay, sir.
Okay, next is Dr. Shashank Prabhudesai. Shashank, are you there? Dr. Jai Singh?
Yes, sir. I am here.
Wall motion, Jai Singh?
Yes, sir. Picture is. Sir, picture is not stable.
Not stable? It's not playing, man.
Sometime 4 chamber, sometime 3 chamber.
No, I'll just give me a second. I'll make the picture stable. Okay.
Yes, sir.
Okay, I'll show you another picture now. Tell me any regional wall motion abnormalities.
Fairly good, sir.
Fairly good. So why this septum is getting jittery, you know? Look, this is not the normal contraction of the septum. Now you got a 3-chamber view, which I wanted to show you. This is not the normal contraction of septum. What is the abnormality?
Again, sir, pause.
Yeah, again pause. थक जाता है ये बेचारा बार-बार ना. This is classical example of left bundle branch block. You know, majority of people at first think that left bundle branch block is almost always associated with abnormalities. That's not true. And how do you prove left ventricular branch block contraction is there is no abnormality. If LVB is present, it's normally associated with anterior wall MIs, majority of them. Then in two chamber view, you should look for anterior wall. If the anterior wall involvement is there along with apical inferior, mid anterior septum and all, then we suspect LAD. Otherwise, we'll not suspect LAD. And you look at this kind of a pattern. This is a contraction of a septum. So before the septum contracts, it goes back to normal shape, then comes back again.
Okay, sir.
So,
Or in short axis view, septum is lagging behind sometimes.
yeah, septum is lagging. That's fine. That's okay for you, Dr. Jaising.
Yes, thank you, sir.
So next, I'll switch over my topic. Give me a second so that I'm able to open my slides. All right, we are set for rest of the slide presentations. So I hope you can see my slides now. The question goes to Dr. Shrikant Rajvilas Gote. Dr. Gote, are you there? One Dr. Gote has left from Sri Lanka and the other Gote has left from our conference workshop. Dr. Vinay Sharma. Dr. Anudeep Reddy. Karanveer Thoward. Dr. Madanik. Tamogna Das. Durgesh Makwana.
Yes, sir.
Durgesh, tell me
Yes, sir.
about the slides, 4 slides, which you are seeing continuously being played over here.
Yes, sir. The first left upper section, the RV appears to be dilated.
Good.
And there is TR also present, and RA is also dilated in 4 chamber axis view.
Okay. Their MR is also, their TR is also.
Yes, sir. MR is also there, TR is also there.
So,
And
so what do you think this patient is suffering from? Concentrate on this slide where LV, RV, LA, RA.
all 4 chambers are dilated.
LV is not dilated, man. I said
Not
yes.
much, yeah.
RV is also not dilated.
Restrictive cardiomyopathy.
Somebody is giving you a hint, man.
Yes, sir. Restrictive cardiomyopathy.
Oh.
I heard that.
You took up that wrong hint.
I heard restrictive cardiomyopathy.
That's what I'm saying. Somebody is trying to help you out. And he's not helping you, he's killing you. So what kind of a condition where you see normal LV, normal RV, LA dilated, RA dilated, which kind of a condition you see this kind of features?
Ventricles are found in atria dilated.
Most common these features are seen in atrial fibrillation or restrictive cardiomyopathy.
Okay, sir. AF.
Like, so remember that normal LV, normal RV, then dilated LA, dilated R. And
Okay, sir.
so let's move on to
Because presence of TR and would be
I'll
there
be
in
coming
AF.
to that in a few minutes. Just give me a second.
Yes, sir.
Dr. Kevin Bora. Kevin?
Yes, sir.
Here is a slide for you. What is the abnormality in this slide? What this slide is telling you?
Sir,
Why these parameters are done in this patient, which we saw just a few seconds back?
Sir, in the left upper corner, pulse wave Doppler is done at mitral valve level. E is bigger than A wave, so it is a
Where is A wave?
E is bigger than A wave, sir.
Yeah, E is bigger than A wave, but where is A wave, man?
Not that. It's very minimal. Actually, it's absent only.
Okay, it's absent.
So it appears to be restrictive filling pattern, sir.
Oh, chalo, okay, then bottom two slides.
Bottom E. Sir, it is showing TS, a tissue Doppler indexer.
Tissue Doppler imaging.
Yes, sir. And in that E prime and A prime is seen, sir, and it appears to be normal to me.
Where is A prime in this segment? This is E prime.
Yes, sir.
Then where is A prime? This is A prime. This is A prime.
Sir, actually A prime is not visible.
If A prime is not visible and here is tall E and almost negligible A, in which condition these features are seen?
Sir, restrictive cardiomyopathy.
Cardiomyopathy or elevated LVDP, or when A wave is not seen, in which condition A wave is not seen?
Atrial fibrillation.
Atrial fibrillation. Now, look at the ECG of this patient. Did not look at the ECG. Look at the ECG of this patient. It is depicted over here. The complexes are at a variable distances.
Yes, sir.
So this is only E wave which is seen, E prime septal, E prime lateral, and then color flow propagation velocity. And all these tells you like this is elevated left atrial pressure.
Yes, sir.
Right. And in these cases of atrial fibrillation, we look at E to E prime ratio, which is more than 11. EVP ratio, this is flow propagation velocity, which is more than 2.5. And isoformal relaxation time of less than 60 milliseconds as surrogate markers for elevated left ventricular filling pressure. Okay?
Yes, sir.
Dr. Ravi Bhushan. Ravi? Ravi, are you there or you've left? All right, Ravi is not there. Dr. Mahapatra, Chandan Kumar Roy Mahapatra.
Sir, good evening, sir.
Good evening.
Sir, here LV is dilated and almost the shape is like globular shape.
Yet dilated and globular. Good. But what else do you see in this patient? Very classical thing is seen in this patient. You know, very classical.
Sir, mitral leaflet.
Okay, let's concentrate on wall thickening abnormality.
Sir, LV, there will be LV dysfunction is there, sir. And the lateral wall is moving, but septal wall, sir, is hello.
Septum where, man?
Sir?
Which part of a septum? Mid, apical, basal? Which part of a septum?
Sir, I am going to, sir. Actually, sir, basal and mid septum.
Basal and mid septum. What are they doing?
So basal mid septum like
Passage.
looking like scar, sir, scar.
Look, this is almost akinetic segments. These are
Akinetic.
hypericoic.
Yes, sir.
And from here, there's a cutoff mark, man. This is the
Yes,
cutoff
yes.
mark. And this is
Yes.
normally contracting.
Yes, sir. I'm saying the middle and
This is
basal.
spongy myocardium which is present.
Yes.
And anything
Sir.
else apart from this in this slide?
RV is also, sir, the septum is totally moves towards the RV, sir.
Septum will move towards RV. Okay. Anything else? When mid and basal septum are involved, which territory do you think these people have?
Sir, it is mostly, sir, LED.
Mid and basal septum for LED. Don't
Sorry,
tell
sir,
me.
right, sir.
Chandan,
Called RCS, sir.
this, look, you will not commit suicide. I'll commit suicide.
RCS, sir.
RCA. When RCA is involved, so what
RB
else we should
dysfunction.
look for?
RV function, sir.
Look at the RV now then. Tell me what is the RV?
There will be also, sir, RV dysfunction.
Look, this RV is not thickening.
Thickening. Yes.
This is just moving. This is sliding.
Yes, yes.
This
Yes.
is not coming inside.
Yes, sir.
Yes. पेशेंट कुछ बोलता है, टेल बता रहा है आपको, सुन ही नहीं रहे उसकी बात को.
Sir.
Suppose a patient आपके पास आया, same this patient came to you with acute infeval MI with RV involvement. What therapy you like to give? Sorbitrate or anything else?
Sir, I will
IV
give
fluids.
not sorbitrate. Sir, I will give fluid and inotrope, sir.
Why I showed you sliders? Just a second. I'll give you a chance. Give me a second. Why I showed this slide is if I suspect RCA, I should always look for an RV.
Yes.
And if the RV which is involved is our line of management completely changes. Changes means changes. Believe my words, if you give him a sorbitrate, he'll die.
Yes.
All right.
Yes.
And
Sir.
this is a classical example where a doctor has to be very, very diligent. Whenever we see mid and basal septum, mid and basal infeval, always spend time for RV, man. Okay.
Yes.
Right.
Yes.
Good. Somebody was addressing something in between. Now you can go ahead.
Sir, you tell about the therapy, sir.
IV fluids.
Sir?
No sorbitrate.
Yes, sir. I told sir IV fluid and
you said
yes.
right.
Yes.
And if the facility should be there, like I say, like if the facilities are there, always intervention. If the facilities are not there for ST elevation or non-ST elevation too also, ST elevation, thrombolysis, non-ST elevation, of course, the other things. All right.
But unusually, sir, LV is looking like dilated, sir. Normally in RCA, right territory, the LV should not be dilated.
It means what?
It means, sir, we should also look for other territory to any other.
Correct. We should look for other territories also to look for. And second important thing is not acute phenomena, it's a chronic phenomenon.
Yes, sir.
Good observation.
There is an echo contrast structure in the LV.
Yeah, it is the echo contrast which you're seeing in LV is seen when we have a poor LV systolic functions. The blood cells, they remain stagnant in the RV. This is known as spontaneous echo contrast. Maybe in 1 week time or 2 weeks time, I'll be able to show my hyper Doppler slides. You know what exactly happened when the blood goes from LA to LV? It forms vortices in the heart. And the flow is such that these vortices are formed like this. And the blood goes through LV, aorta. Like the blood will go like this, it will form vortices. And these vortices will go from aorta. When the blood remains stagnant and the LV is not contracting, then you find a lot of spontaneous echo contrast and there's a lot of vorticity.
It's like, sir, LA smoke during MS.
LA is normal. LA is a different ball game. LA could be normal or LA could be bigger. Like
No,
you
I
said,
told sir like LA smoke during severe MS.
yes, exactly. Okay.
Sir, one thing, sir.
Yeah.
Sir, the role of fluids are there, sir, definitely. But sir, role of atropine is there also there, sir? If RC also supplies SA node also.
If bradycardia is there, obviously, yeah.
Okay. Okay, sir. Thank you.
Dr. Yogesh Namdev Patil.
Yes, sir. Yes, sir.
Yogesh.
Yes, sir. I'm there.
Tell me the abnormality.
Yes, sir. Sir, we are looking into the plaques view. The LV looks like concentrically thickened.
Interventricular septum.
Interventricular septum, yes, sir. Yes, sir.
Don't say LV is thickened.
I'm so sorry. Interventricular septum is thickened. Along with that, I'm so sorry. I'm not able to appreciate. There is a mitral. No. There is in the second slide. There is a anterior mitral leaflet coming near to that IVS is seen, suggestive of systolic anterior motion of that wall.
Correct.
Yes,
look at the feature is, look at the thickness of septum over here. Look
yes,
at
sir.
the
Yes, sir.
posterior wall.
Posterior wall. Yes, sir. Yes, sir.
And
yes,
then
sir.
with systole, this is being pushed towards LVOT, towards interventricular septum, and this remains unguarded so as to have a mid-systolic mitral regurgitation.
Yes, sir.
And how do you prove this? We always go
with M mode.
By
M mode.
M mode echocardiography.
Yes,
so how do you
M
see
mode.
in M mode echocardiography? This is QRS complex, T wave.
Yes, sir.
And then during diastole, the mitral valve will open. But
yes, sir.
This mitral valve will go systolic anterior motion even during systole.
Yes, sir. Yes, sir.
And you will find a gradient in this subset of population.
Yes,
what is the gradient cutoff value in this patient?
Sir. 45. I just
Resting
forgot. Sir.
LVOT gradient of more than 25 is significant. After
Yes, sir.
stress is 30 is more than significant. But recently one paper has said 35. So resting 25, stress 35 to 30 to 35.
Okay. Okay. Sir. Okay. Thank you.
Great.
Thank you, sir.
Thank you.
Thank you, sir.
Sir, can I ask one question?
110%. I'm there to answer your question, man. How can you say, can I? Sir, you should say, I want to ask a question.
Okay, sir. Sir, sometime when we are doing echo at bedside, then ECG lead are not attached to machine. So at that time, in plaques view, please show in this picture the same. Unable to identify that it is SAM or AML is long.
Are you married?
Hello?
Not yet?
Married, sir.
Married. Okay. You know, the best part of the marriage is adjustment. Majority of time we are doing echocardiography without any ECG leads. Everyone knows about it, and that's doing ICU setups. When we start suspecting this kind of a setup, what do? We start looking for leads. Because otherwise, how do I know about it? Look, in this slide, if I have to really say that this patient has got mitral systolic anti-motion in the mitral leaflet, I can only say that when we have a lead attached to the patient's lead. Otherwise, we have to just presume, look, this is systolic contraction, this is systolic contraction. We should have the M mode, systolic anti-motion mitral valve over here. fairly unusual, we'll find these kind of things. So whenever you suspect something, go back and have a lead. And if I were in your position, whenever I go to ICU even, I'll take my machine with the leads only. And I'm a person who is a lead, electrode savior also. So I'm using electrode, not in new electrode in every subject. What I need a ECG gating. So why should I use a new electrode in every patient? So I always take to echo labs, from echo lab to ICU with the ECG gating, because we may miss many things without the ECG gating. Okay.
Okay.
Dr. Majrul, are you there? Dr. Majrul,
Yes, sir, I am
Islam.
here.
Okay.
Yes,
Majrul.
sir.
Majrul, tell me the abnormality in this patient. A very classical abnormality in this patient.
Sir, this is apical 3-chamber view.
Okay. A little oversight for you. Dr. Nida, would you like to take this question?
Yes, sir.
Go ahead. Tell me the abnormality, Nida, in this patient.
Sir, mid cavity.
Mid cavity what?
So mid cavity obstruction, but the gradients are not that significant.
Right. Great, Nida. Good job.
It may be because of tachycardia, sir, or
it could be because of tachycardia. I agree.
Yes, sir.
Or
caudal SAM.
Caudal SAM or
hypovolemia, sir.
good. Great job, Nida. God bless you.
Yes. Thank you, sir.
So for everybody, look at this segment over here, you know.
Yes, sir.
You find a lot of turbulence out here. Let's look some
Yes,
other picture first. Then we'll realize like whether there is turbulence or not. Anyway, there's no other slide, but I will show you subsequently. There's a lot of turbulence and aliasing over here. And when we put a continuous wave Doppler across it, we are getting a gradient of only 1.5, which corresponds to 15 millimeters of mercury. So this is a classical example where patient does not have any illness. And it's like overuse use of diuretics and other things, which making is like little help, not much. Good, Nida. Dr. Sai Prasad. Sai, are you there? Dr. Manu Kapil? Dr. Clay? Dr. Clay, are you there from Tanzania? Majrul, you like to take this question?
Yes,
Dr. Madanik?
Good evening, sir. Yes, sir. Yes, sir. Yes, sir. I'm traveling right now, sir. But I'll just see, sir. I'm seeing it on my mobile screen. Just a second, sir.
I just saw you joining a few minutes back.
Yes, yes, sir. Yes, sir. I'm actually traveling in a bus. Just 1 second, sir. Sir, this is first view is a apical four chamber view, sir. Here the LV appears to be dilated, sir. Second thing is mitral wall also appears to be thickened in the first view. The second view is apical three-chamber view, sir. In this, the aortic leaflets also appear thickened, sir, and hello, am I audible, sir?
Madani, you are audible.
Yes, sir. Yes, sir. And
when something is not good, it takes me longer time to digest, you know. Where is LV which is dilated? Concentrate on mitral valve in three-chamber view. You will find the answer. Look at the long cords. They are beating.
yes, sir.
around the
It's systolic anterior motion of the mitral wall, sir.
not mitral valve.
Sam.
They're cords which are dancing cords, man. Look at that crisscrossing like a Christ. With every systolic contraction, they are. If you can see my video, just a second. If you see my hand movement, they're crisscrossing like this. Concentrate.
Yes, sir.
It's a very classical finding where there's a caudal SAM is present. Like both segments, both cords, they are crisscrossing like this.
Yes, sir.
And these cords are getting into LVOT now.
Yes, sir.
And when they get into LVOT, what will happen? They'll produce caudal SAM.
Sam. Yes, sir.
And when caudal SAM would be there, you'll find a significant gradient across LVOT.
Right, sir.
And these people, they do not have any problems. They majority of time they come with a chest pain while they are walking.
Yes,
now look
sir.
at this caudal SAM. Look, now this is very classically seen. So,
yes, sir.
So we do see these kind of abnormality while doing a stress. Only answer for them is give them a beta blocker. And if you want to confirm, give them a coronary angiogram. And this is a abnormality which will resolve by just a beta blocker. Let them not go towards tachycardia.
Yes,
so
sir.
very, very specific things you should remember, you know.
Yes, sir.
All right. And this is the same patient where you see a dynamic LVOT gradient. It's going up to almost 3 meters per second. Although I'm not able to get a complete graph in it, initial part looks to be okay, but subsequently getting a dynamic LVOT gradient, the long piking of in first, second, fourth complex. This patient came to us for a stress echocardiogram. We did stress. We found this gradient from 30 going up to almost 66 or 70. Caudal SAM was present. We said this is one of the pathology for his chest pain while exertion, and we gave him a beta blocker. That's all, 50 milligram of metoprolol. Then he was not satisfied. Went and had to do an angiogram. Angiogram was absolutely normal. Then we did again the same patient when he was not comfortable. And many people, they did not appreciate this caudal SAM. We said, let's show them caudal SAM. And we did show the caudal SAM, and we did a transesophageal echo to prove ourselves. Okay?
Yes, sir.
I'll stop over here and I'll come back to next set of questions. Every echo tells you, man, there's something going on this patient. Nobody can say no, nothing is going. Some other very, very important things, very, very clips I'll show you. Just give me a second. And I've got a couple of questions for you, Madanik. Don't go away, okay?
Sir, I'm there, sir. I'm there, sir.
So we are all done. I just missed up Dr. Majrul Islam. Majrul Islam, tell me what I'm doing in this slide. Majrul, are you there?
Yes, sir, I am here.
Tell me what I'm doing in this slide.
Sir, measuring the
Measuring what?
ASD, measuring the size of the ASD, sir. No, sir, measuring the size of the RA volume, sir.
One more chance to correct yourself. First of all, ASD is over here, right? And so I'm not measuring
Yes,
ASD.
sir.
You said RA volume. How can I measure by RA volume by these things? What I'm measuring? I'm measuring long axis of RA, short axis of RA. And this line is annulus line.
Yes, sir.
So it is normal or dilated?
Dilated, sir.
And what is the maximum size for dilated? Do you remember the size?
Sir.
RA dimensions are 46 into 40 millimeters per meter square area. This is only one right ventricular segments where we do indexed RA wall, RA dimensions, long axis and short axis.
Yes.
So this was 46 into 40 millimeters.
Yes.
No, I'm sorry, this is wrong, written over here. The absolutes are this, but the normal is only 25 to 19. So let's see what is R values. R values is 47 and 46. So this is the first segment which we drew. This is the second segment. Yes. This is the third segment. Second and third segment. 47 and 46. The RA is dilated. And I must share many patients coming to echo lab for evaluation of right side lesions. RA is dilated. RV could be normal in those subsequent populations, right?
Yes, sir.
Good. Dr. Balram, are you there?
Yes, sir.
Balram, next question is for you.
Sure.
What I am doing?
Well, we're doing the same thing with the right ventricle.
Okay, normal, abnormal.
I am not sure, sir.
So you have to remember the dimensions. 83 into 47. That's long axis. 59 to 83 mid segments. Then basal segments. So you have to remember all these segments to talk about long axis, short axis. This is long, this is short, this is annulus diameter. And the best answer is print them up and see them whenever the COPD patient comes, whether it's normal or abnormal. Okay, Balram, that's important.
Okay.
Before you leave, tell me what is happening to this patient.
So it looks, at first I was just thinking ARVC.
Okay. ARVC will find good tuberculations, no doubt about it. That could be ARVC. What else?
So it seems like the right ventricle is being pulled towards the left ventricle.
Okay.
And the RV seems larger than the LV.
LV.
Looking at the thickness, I don't know, it seems like maybe the apex of the right ventricle is not moving appropriately. And also right
reverse, apex is contracting, the basal segments are not contracting. See carefully now.
Yes, sir. And the right atrium seems enlarged.
Correct. What else? You are missing a very important, significant finding in this patient.
I was thinking this could be from pulmonary hypertension.
It could be. there's some amount of pericardial effusion which is present.
Okay, yes, sir.
That video was missing. Anyway, good attempt. God bless you. Take care and just go through them again and again.
Yes, sir.
Dr. Utpat, get ready.
Yes, sir.
Tell me the abnormality in this patient. Same patients, I have modified my frames. What do you see in this patient?
RA, RV are dilated and septum is moving
RA
towards L.
RA is definitely dilated. I'm not sure
Okay.
about RV.
Even the effusion is seen around the RA wall.
Okay. Superior to RA, right?
Superior.
Anything else? Look at the IES, which is bulging towards left hand side, this interictal septum.
Increased RA pressures causing
RA pressures are not increased only, they are more than LA pressures.
LA pressures, more than LA pressures. Septum bowing towards LA.
Correct. So that's what we look forward, man. All right. That's fine, Dr. Utpat. We'll move on to next subject. Dr. Ghansham Motisaria.
Yes, sir.
Pechano.
Yes, sir.
What is the abnormality?
Septum is hypertrophied.
Okay.
And posterior wall is also looking hypertrophied.
Posterior appears to be hypokinetic. Septum is thickened.
Yes, sir.
What else?
Some amount of pericardial effusion.
Very good. This pericardial effusion is there in this patient, right?
And RV also dilated. Looking dilated.
Appears dilated. Dude, I do agree with you. Do you find anything like sparkling wine? Everything is so bright in this patient. When you look
Yes,
at
sir.
the leaves,
Yes, septum
when you
and
look at the
posterior
wall,
wall.
you look at the pericardium, everything is so brighten up.
Yes, sir.
Oh.
Myelinosis.
Could be. I'm not really sure about it. That could be. Okay. Next subject. Next subject is Dr. Ghansham Motisaria.
Yes, sir.
Ghansham, tell me one single finding. You are done.
Sir, RA pressure is more than LA pressure.
I don't see R in this picture at all, man.
Sir, this is short axis view.
This is not RA. This is RV, man.
Sorry. RV. RV. Sorry. I want to tell RV, but somehow RV is RV pressure is higher than LV pressure
during
systole.
During systole.
Systole.
Right. Systole. Correct. Yes. Suppose my blood pressure is 110. What would be the RV systolic pressure in this patient?
More than 110, sir.
Perfect. So I hope everybody is able to understand what I'm trying to say, what Dr. Ghansham is saying. With every systolic contraction, this septum is bulging towards left ventricle. It means during systole, RV systolic pressure are more than LV systolic pressures. Otherwise, this septum is like
round
this.
shape.
And this is very good evidence of looking for PA pressures or TRZ gradients.
Yes.
Because if I have just a systolic blood pressure is 100, I can safely say that my RV systolic pressure is more than 100 millimeters.
Yes, sir.
Right. Good attempt. And there's small amount of pericardial effusion.
Systolic volume overload.
Systolic
volume overload, sir.
I'm sorry. Say it again. Systolic
volume overload.
Volume
RV.
overload. No. How can you say systolic volume overload?
The flattening of IVC.
Okay. What exactly you wanted to say is, I'll say in a different fashion. whenever the LV contracts during systole towards LV, it is normally a D-shaped and further becomes like sickle shape during systole. So when it happens both during diastole and systole, this is pressure overload. When only D-shaped ventricle happens during diastole, no in systole, it means it's a volume overload. Okay?
Yes, sir.
Volume overload would be only one, like only during stationary picture. And when systole makes it more vulnerable, like sickle shape, then is known as pressure overload. Anyway, it's good. Like I'm just showing you a couple of things which may interest you. All right, Dr. Rahul Kenkan. Rahul?
Yes, sir.
Tell me.
So this is a modified view.
Modified of where? Modified of Russia?
Modified
Ukraine?
short axis. Modified short axis view, sir.
This is short axis modified view.
Yes, sir. And we can see a TR jet.
TR jet is here, man. This is a large TR jet.
Yes, sir.
Look at the mitral valve opening in this 3 dimensions.
Yes.
Look at the small pedicle if you over here, there. I'm asking you findings. I'm not asking more than that. Okay.
Sir, a moderate TR with
moderate TR, Kenkan. Suppose this vena contracta is Kenkan 5 millimeters. What you will say the severity of TR is mild, moderate, severe, torrential, or massive?
Sir, vena contracta 5 millimeters.
Centimeter.
So moderate.
It's yeah, you can say moderate because this vena contracta is width is dependent on like less than 3, more than 7. Less than 3 is
Yes,
mild.
sir.
3 to
So
7
less
is
than
moderate. More than 7 is severe.
Severe.
Then one more figure is 14 and 28. 14 is massive and 28 is, no, 14 is torrential and 28 is massive.
Massive. Yes, sir.
Good. Anyway, it's fine, Rahul.
Yes, sir.
Reasonable attempt. I'm not saying good, bad, or it's good. Dalip, then comes Dr. Jigna and Jayanti. Jayanti and
Yes, sir.
Jigna Viresh.
Yes, sir. Yes, sir.
What are we looking for?
Sir, TR jet, we are measuring TR jet for
Okay.
peak PAP.
Big PAP. How
Yes,
big?
sir.
Look, the TR jet is only how much? 3.4.
46. 46.
That's overestimation of a TR
Yes,
jet.
sir. Overestimation. Yes, sir.
Look, TR jet would be somewhere here itself.
Here,
2.5
yeah.
to 3.
2.5. Yeah.
On one side, I'm saying the pressures are very high. And
Yes, sir.
TR jet is only low. What does it mean by? What does it suggest? Why this is happening? When we drive less pressure gradients, but
RV dysfunction?
RV dysfunction. Who said this word?
Yogesh.
Pardon?
Dr. Yogesh, sir.
Yogesh. Good, Yogesh?
Yes. Yes.
If you are underestimating TR jet is, then RV dysfunction is happening. Second important thing is, look at the contour of TR jet. Look, this is tongue shaped. If it becomes sharper acceleration time and longer deceleration time, then it becomes like TR jet of severe TR jet with less gradients. Please silent your mic. Request. Third important thing is when RV-RA pressures become equalized, non-coaptation tricuspid valve leaflets, then the pressure also equalizes. So remember, like these are very, very important things. Sometimes we find a very small TR jet gradients, but PA pressures are very elevated. In this patient, this is the same patient where we expect that TR jet velocity should be, TR gradient should be very high. Because we saw a septal bulging towards LV during systole. In fact, this is the lady who came yesterday for evaluations. All right. Let's move to Jayanti. Are you
Yes,
there?
sir. Yes, sir.
Okay, Jayanti, tell me what is I'm seeing.
Sir, end diastolic pressure of pulmonary artery.
इतना सारा अच्छा बताओगे तो सब लोग डर जाएंगे तुम्हारे से.
Early diastolic velocity, sir, pulmonary artery ka we are saying.
Good. This is pulmonary artery velocity, pulmonary regurgitation velocity. PR velocity. This is early, this is late. So what we are measuring? We are measuring late velocity. Late velocity is 2.4724. So it means its end diastolic velocity is 24 or LA mean pressures are 24 in the absence of any lung conditions, lungs lesions.
Yes, sir.
All right. Dr. Rajit Shankar Mote.
Yes, sir.
Are you there?
Yes, sir.
Question for you now. Tell me, Rajit, what you're seeing?
Pulmonary regurgitation, sir.
Everybody is seeing that. What do we see on the left hand side with pulmonary regurgitation? We are seeing a regurgitant flow pattern.
Yes, sir.
And I have marked this in the early diastolic phase. What is the importance of this marking and why I have done this?
It's equal to pulmonary artery systolic pressure.
Good. It's not equal to pulmonary artery systolic pressure. It's equal to, if you add
Mean
RA pressure to it, it becomes mean pulmonary artery.
Pulmonary artery pressure.
Mean.
Yes.
Where anything more than 25 is abnormal. Good attempt. Dr. Bhatkar.
Yes, sir. Good evening.
Tell me the diastolic function of this RV.
Sir, in this A wave is very much greater than E wave. Sorry, E wave is greater than A wave.
EA ratio is almost, how much is the EA ratio?
2.35. Yes,
what
sir.
does it suggest?
So it is elevated. So it is type 3 diastolic dysfunction.
In RV, we do not talk of type 3. We talk of normal or elevated.
Okay, sir. Yes,
so it is an elevated.
Yes, elevated right atrial pressure, right ventricle,
Right
filling
ventricle
pressure.
and diastolic pressure.
Yes, sir.
Okay, good. Madanik, this is for you or for Nida Khan.
Yes, sir. I'm there, sir. Yes, sir.
Go ahead, Madanik.
Sir, we are doing the strain analysis of right ventricle, sir. In this is in this view, the mid free wall of RV shows reduced strain pattern, sir. And
this is mid free wall, right?
Yes, sir.
And this mid free wall is depicted over here.
Yes, sir.
Okay.
The apex and the apex looks normal, sir. Strain pattern looks normal at that side. The
Okay.
septal strain patterns have not been evaluated because I
We
think
don't see septal. We are looking at apical, mid, and basals.
basal. Yes, yes, sir.
Look, apical is almost is
Normal.
reduced but preserved. Look, this
Yeah,
is
preserved.
apical.
Okay.
It's
Yes,
almost
sir.
8 or so. Mid is positive deformation is happening. It means it's not contracting, it's relaxing, going out.
Yes, sir.
Same here for basal. Is also going out at the time of systole. So they
Slightly
are
reduced, sir.
not contributing to LV filling.
Okay. Yes, sir.
So this is very important factor. And if you look at this, if this is functioning, this is not functioning. The selective hypokinesia of mid and basal RV free wall.
Yes, sir.
Could be normal or reduced. So
Yes,
this
sir.
is very, very important differentiating pulmonary embolism patients. Like
Yes, sir.
in those subset of population, you will find a patient having a clot, which is there in the RV RA, and this kind
Yes,
of
sir.
picture will tell you if his two-dimensional strain is also reduced with apical sparing and rest two segments are reduced, it means we are dealing with pulmonary embolism.
Yes, sir. Yes, sir.
And this is found to be very useful during emergency to differentiate. All right, Madani,
Yes, sir.
good attempt.
Thank you, sir.
Right. So, Dr. Nida, are you there or you have left now?
Yes, sir. No, sir.
Okay, Nida. Now this is for you.
Sir, RV dilated with hyperkinetic RV apex.
Just look at the film complete, you know.
1 minute, sir.
This is the same patient whom we showed a two-dimensional strain which was reduced. We gave a contrast.
Yes, sir.
This is agitated saline contrast infusion. And with this, it is the RVO pacification, but there was no flow across intraatrial septum or arteriovenous levels. Okay. So next is Dr. Jai Singh.
Yes, sir.
You want to take up this question?
Okay, sir.
Tell me what is there.
RV dilated.
RV is dilated. I do not know much about RA because RA is cut off over here. I don't see RA completely. But RV is dilated. What else you see in this patient? Speak loudly.
I'm thinking, sir.
Okay. Anybody else would like to take this question? Kanvi, are you there?
Moderator band is taking.
Look at the moderator band, which is very clearly seen. Look, this is moderator band. This is not thrombus or vegetation.
Moderated band is thick.
Look, calcified moderator band.
Yes, sir.
Apex is all clean. All right. Dr. Ishwar Agarwal, are you there? Dr. Hiru Alami?
Sir, thank you, sir. First of all, in parasternal long axis view,
Go ahead.
Beyond the RV, there is suspected of pericardial effusion.
Hiru. Okay, agreed. Something very different, Hiru. I have published a paper from your hospital also.
RVOT obstruction?
No, there is no RVOT obstruction. It's clear.
The first
Look at the
there is
mass
some.
over
Is
here.
there
Look
any
at the
is there any
mass over here.
mitral valve? There is vegetation
No, there's no vegetation. There's a
or
mass
thrombus?
in LA cavity. This
Yeah,
is a mass.
myxoma.
Oh, this is not myxoma. It is a very interesting story. This guy came with multiple masses in LA, and I couldn't get the slide earlier one. And he had a chest lesion suggestive of tuberculosis with pleural effusion. It was not my patient. My colleague gave him steroids along with ATT. Everything disappeared. This is only which is left out here. So now retrospectively, we can say that this patient was possibly having tuberculosis of the heart, or they were tuberculomas. I'll be able to show you this patient by next week because I'll be presenting this in my upcoming Saturday conference.
Okay, sir.
So the question of showing this slide is, look, people will see 10 things, but concentrate. This is a mass in the LA cavity. That's all.
Yes, sir. Yes, sir.
All right. So next is Umesh Rajur. Are you there, Umesh? Then if Umesh is not there, then Dr. Rahul Gore.
Hello, sir.
Durgesh Makwana. Durgesh, are you there? Kevin Bora. Majrul Islam, you can take it
Hello.
now, Majrul.
Hello.
Majrul, go ahead.
Sir, I'm Kevin. Sir. Hello. Sir, I'm Kevin.
Kevin, go ahead.
Yeah. So it will be 368 minus 254 divided by 254. So that will RIMP, sir.
That will be the RIMP. What is the normal RIMP by this method and what this method is?
So this is right-sided myocardial performance index method, sir.
Correct. And is done by tissue Doppler imaging of RV free wall.
Yes, sir.
Normal is 56 or less than that, 0.56 or less than that. The advantage of this method is what?
The normal is 0.42.
0.42.
42 is different method. This is
Impulsive Doppler.
That's by Doppler. This is by tissue Doppler.
Okay.
42 is by other method. That's why I brought you this slide.
Sir,
And the positive point of this method is
sir, this tells that the importance of this is it will tell us the prognosis of patients suffering from COPD.
Yes, it higher the RMP, poor is the prognosis. Second important thing is like we are looking at systole and diastole at the same time. But in other methods, we have to calculate PVET, pulmonary artery ejection time. Then we have to calculate TVCO, tricuspid valve closing and opening time, and two different frames. Here we don't call them in two different frames. Anything less than 56 is considered as normal, 54 or 56. More than that is abnormal. All right?
Sir, in this case, formula remaining same.
Formula is A minus B. What is A is tricuspid valve closing and opening time.
Yes.
So here, where does the tricuspid valve closes and opening? This is RV free wall is systole. This is diastole.
Diastole.
Correct?
Correct.
Okay. These are two pictures from a patient. Like this question goes to Chandan Mahapatra. Chandan, are you there? Chandan? Everybody is tired, I believe. Rahul Gore? Okay. Dr. Ankan Patel? Umesh Rajur. Jayanti. Jayanti, beta, are you there?
Yes, sir.
Tell me how to calculate peak pulmonary artery pressure from this. Last few questions, and then we will stop.
So 4V square, the gradient which we are getting, then 4 and 59 square.
59 square. Oh.
4V square.
This is already squared, beta.
Plus adding right atrial pressure.
So we will add, sir, RAP, right atrial pressure.
With 59.88, we'll add RA pressure. And here is RA pressure. How much is RA pressure from this slide?
3.
3 or 5. I agree. Done. So my peak pulmonary artery pressure is 59. If I take it for comfortability, 60. 60 plus 3 is 63. Normal or abnormal?
Abnormal, sir.
Any velocity which has got a more than 2.75 velocity is elevated. So this is almost 63 millimeters of mercury peak pulmonary artery pressures. So they are abnormal, they are elevated. Okay, good.
Yes, sir.
And
thank you.
Jagna, are you there, Jagna?
Yes, sir.
So same slide gave me the mean pulmonary artery pressures.
Mean pulmonary artery pressure, sir. So from TR jet we can trace it, or else so we can trace it.
I'm not going to trace it for you. I'm going to get the answer from this slide only.
Sir,
Wait a minute.
So we can do VTI and then we
Formula.
Multiply by 0.6.
0.6 plus 2.
Multiply by 0.6.
Yeah, this is what exactly is. You calculated peak pulmonary artery pressure as 63. Correct?
Yes, sir.
So what you should do in this patient is you take peak pulmonary artery pressure 63, 0.6 into 63 plus 2.1 will give you mean pulmonary artery pressures.
39.1 probably.
Yes, sir.
Why do you want to trace it? I did not expect the question answer from you like this. If you are calculated peak pulmonary artery pressure is multiplied by 0.6, 63 into 0.6. 63 for calculation purposes, let's make it 60. 60 into 0.6 will be 36. Right? And 36 plus 2.1, 38. 38 would correspond to moderate pulmonary artery hypertension. So what's the formula for pulmonary artery hypertension? At what level we say normal or abnormal?
Sorry, sir.
What level of mean pulmonary artery pressure will say normal or abnormal?
So mean 20 so less than 25 is normal, and then 25 to 35 is mildly elevated, and then sir above 46 elevated, between that sir 35 to 45 moderate, sir.
Correct. So it belongs to moderate pulmonary artery hypertension.
Yes, sir.
Correct?
Yes, sir.
So now you remember it? You're not.
Yes, sir. Yes, sir. I'll remember.
Great.
0.6. Yes.
Wonderful.
Yeah.
Okay. Last question. And I want to give the best person, that is Dr. Jai Singh. Jai Singh, tell me the systolic function of this patient.
Yes, sir. Systolic function.
Yes. Normal, abnormal. If normal, why normal? If abnormal, why abnormal? Jai Singh, don't disappoint me, man. Okay, Majrur Islam.
Yes, sir.
Tell me systolic function.
Normal.
RV systolic function, normal, abnormal in this slide.
It is abnormal, 0.44.
Yeah, the point should be normal.
Abnormal, sir.
Abnormal.
Yes, sir.
Why? Okay. By tissue Doppler imaging, how do you measure systolic function?
It's normal, sir.
Yeah, it's normal. Just hold on for a second. It's normal. How do you measure systolic function by tissue Doppler imaging of RV?
E prime more than 9.5.
Pardon?
E prime more than 9.5.
E prime. You are correct. 50% correct, 50% wrong. S wave is more than 9.5. Not the E prime. So this is S wave, systolic thickening. This is 15. So LRV contraction is normal. I did not measure it. I kept it for surprise. I know somebody will calculate these values to tell you about systolic functions. So if you look at tissue Doppler imaging, this is S wave, this is E prime, small E prime, E prime over here, A prime over here. So what we are looking for systolic contraction is, we are looking for S wave, which is more than 9.5, which shows a normal RV systolic function. Okay?
Okay, sir.
Okay, sir.
Great. So I think we are done for today. And good attempt for everybody. I can only say that. And we should read more and more. And why I did not want to miss this class, now you could have got answers. Like I wanted to show all these slides to assess your knowledge about CAD, LV function, not CAD, LV functions, systolic and diastolic, then cardiomyopathy and RV. Okay, anything anybody want to say before I close it down for today?
Sir, I have a question, sir.
You go ahead.
Ji, sir. Sir, first of all, last week I found a patient. The patient is a postpartum cardiomyopathy patient. The patient's ejection fraction is about 35 to 40%. There is global hypokinesia of LV, but there is eccentric severe MR, but there is no AML or PML prolapse. But why this occurs, sir? Is there any pathophysiology why this occurs? I cannot found the pathophysiology, sir.
Well, look, when these LV they dilates, they do not
Yes, sir.
dilate proportionally to each and every segments. What is Takotsubo? What is this postpartum cardiomyopathy? It's in fact, it's really look at it. It's a myocarditis kind of a feature.
Yeah, yes, sir.
Correct. So
Yes,
the
sir.
jet could be eccentric or jet could be central. It could be in either form. It's nothing to do with that.
Oh,
But
okay,
you
sir.
were
Okay.
expecting the jet should be central. Correct?
Yeah, yes, sir. Because due to annular dilatation, I think this should be central.
Yeah, but it can present in any formats.
Okay, okay, sir. Thank you, sir.
Right. Anybody else?
Sir, Nida here.
Nida, go ahead.
Sir, the slide which you showed me, the bubble contrast slide.
Yes.
Is it for, to look for the shunt or to look for the clot, sir? Why did you do bubble contrast?
Nida, why we did a contrast to this patient was when RV, RA, they are dilated, the first thing which comes in our mind is whether there is any shunt across this interstitial septum or at the level of arteriovenous connections or at the level of liver. This patient was referred to us for any lung pathology where the patient has arteriovenous communication. So if it's an intraatrial septal shunt, within 3 cycles, you will find a shunt across it.
Yes.
And if it's from arteriovenous, you'll find after 5 cycles.
5 cycles.
and the flow would be seen through pulmonic veins.
Yes.
So that's why we did in this patient the agitated contrast saline echo.
Thank you, sir.
Okay,
Sir,
go ahead, Jesse.
sir, sometime in echo, we seen that only basal septum is a little bit thin, and mid septum is looks like a sigmoid type septum,
Yes.
and all the LV function is looks like normal.
Normal.
Then it's a normal phenomena, or we would like ignore. Okay.
Basal inferior wall, basal septum. These are two dubious things which always try to, which we always think that we should report as hypokinetics.
Okay, sir. Yes, sir. Got it, sir.
All right. Any other questions before we close it down for today? All right. I'll say Shabba Khair, stay safe, and see you next week. Good night. Bye-bye.
Good night. Good night, sir.
Bye-bye.
That's all.